Welcome, everyone. My name is Kira Bradford, and I am co-PI and technical lead of the HEAL Data Stewardship Group. I want to thank you all for joining us today. Today is our 9th installment in our Fresh Fair webinar series, and our topic is Common Data Elements Getting More Common All the Time. We will be focusing on describing the HEAL Common Data Elements program and applications of CDEs and existing HEAL efforts, followed by a panel discussion and Q&A with experts working with CDEs. This webinar will consist of 2 brief presentations, followed by a moderated panel discussion, and then a live Q&A. If at any point you have a question, feel free to type it into the Q&A box. We are joined today by our largest panel of experts yet. So we have Kathy Sword of Pain ERN, Diane Hartford of the Heel Cde program, Meredith Adams of the NIH NIBIB Mentored Clinician Scientist program and Empower, and Andrew Siddons of the Heel Cde program. I will now go through and introduce each one of our guest panelists. Kathy Sword, PhD, is a professor in the College of Nursing at the University of Utah. Sword has extensive experience in biomedical and nursing informatics, including terminology, vocabulary management, and data information standards, and the design, development, and implementation of decision support systems and databases. She has a diverse clinical background, including clinical nursing, education, and administration. Her current research is in the area of clinical research informatics, including clinical and translational research, the unique aspects of managing research information in special populations, and informatics to support exposure science and sensor monitoring. Sword earned a PhD in nursing informatics from the University of Utah. Also with us today, Diane Hartford. Diane is a senior IT project manager at the University of Utah Health. She received a master's degree in human development from the University of Utah, and she has 20 years of project management experience and is a certified project management professional. She and her team support the HEAL CDE program by tracking PI submissions, improving processes, and reviewing CDE measures. Other projects include mitigating the NEMSIS data bank and systems from on-premises to the AWS cloud. She is responsible for budget, procurement, and professional services, tracking and reporting the progress of the internal project team and the 3 external organizations. Additionally, Hartford leads the IT project management office at the Data Coordinating Center. Also with us today, Meredith Adams Md is an associate professor of anesthesiology at Wake Forest Baptist Health and the only NIH researcher board certified in anesthesiology, pain medicine, and clinical informatics. She is currently funded by the NIH National Institute of Biomedical Imaging and Bioengineering to study opioid response phenotypes for people with low back pain through the Mentored Clinician Scientist program. Additionally, she is a member of the Pain Mechanisms Lab at the Wake Forest School of Medicine and teaches and practices clinical pain medicine at Wake Forest Baptist. Her research interests include novel approaches to pain education and pain biomedical informatics. She received her MD from Tulane University School of Medicine. Also on the panel today, Andrew Siddons, Master's of Public Health, is a scientific technical writer working at the Office of Pain Policy and Planning within the National Institute of Neurological Disorders and Stroke. He supports the work of the NIH Pain Consortium, the Interagency Pain Research Coordinating Committee, and the NIH HEAL Initiative, including coordination of the HEAL Clinical Pain Common Data Elements program. And presenting today are Laura Wandner of A2CPS and the HEAL CDE program, and Gaurav Bhatia of the HEAL Stewards. Please note that Laura's presentation today is going to be pre-recorded, but we are super grateful that she has provided us with some key information through her presentation. I will now introduce Laura and Gaurav. Laura, PhD, is a program director in the Office of Pain Policy and Planning at the National Institute of Neurological Disorders and Stroke. She manages programs within the Acute to Chronic Pain Signature Program and the Helping to End Addiction Long-Term Initiative. She also leads the HEAL Initiative's Common Data Elements Initiative. Wandner, a clinical health psychologist, continues to treat pain patients at Walter Reed National Military Medical Center. Wandner received a BA in psychology and government from Connecticut College and her master's and PhD in clinical psychology from the University of Florida. Wandner completed her internship and postdoctoral training in clinical health psychology at the Connecticut Veterans Administration. And then last but not least, Gaurav Vaidya, PhD, is a semantic web technologist at the Renaissance Computing Institute at UNC Chapel Hill. He is also a software developer for the HEAL Data Stewardship Group, where he has been working on incorporating HEAL common data elements into RENCI's semantic search engine, DUG. He has previously worked on CDE-related initiatives as part of the National Cancer Institute Center for Cancer Data Harmonization. And with that, I will now transition from sharing the presentation over to sharing Dr. Wadner's presentation. So please bear with me as I switch over.
Good afternoon. My name is Dr. Laura Wadner, and I'll be giving a brief overview of the HEAL Pain Common Data Element Program. The NIH HEAL Initiative decided it was important to establish a comprehensive core outcome set of chronic pain and acute pain that all funded HEAL pain researchers could use within their studies. The core outcome sets were developed so they could be used for all pain conditions assessed with HEAL. I want to give a quick overview of the HEAL Pain Cde process. First, a literature review was conducted to identify pain domains that are typically assessed in clinical trials or clinical studies. And then NIH program staff collected the pain domains from the literature review and ultimately reduced the list of pain domains based on which domains could realistically be assessed in all HEAL clinical pain studies. Then NIH provided the list of domains to impact, where they provided feedback on the pain domains selected by NIH. A literature review was then conducted to identify patient-reported outcomes, PROs, also known as questionnaires, to address each pain domain. NIH program staff collected a list of PROs, and NIH selected PROs based on the number of questions in the questionnaire, the validity and use in clinical trials, and use and validation across populations. Impact then provided feedback on the PROs and recommended minor edits. Once the HEAL PIs were awarded, the HEAL PIs also provided feedback on core domains and PROs, and ultimately NIH finalized the core pain domains and core PROs. I want to quickly define what I mean by core CDEs. They are a minimal and defined set of pain domains and questionnaires that all HEAL pain clinical studies or trials are required to collect. Here you can see the 9 pain domains that all adult clinical studies have to assess within their studies. And you'll see that although the domains are the same, we have slightly different battery of questionnaires for acute and chronic pain based on our literature review. The pediatric studies use the same domains as the adult CDEs, but questionnaires were selected that have been validated in a pediatric population. The HEAL CDE program also requires that clinical pain PIs use a core set of demographic questions in their studies, which you can see listed here on the slide. And the HEAL CDE program also has supplemental CDEs, which are defined as a comprehensive set of screening tools selected by HEAL PIs for use in their studies. They may be unique to the study, pain condition specific, or study relevant measures, and PIs have submitted over 500 distinct supplemental questionnaires to the HEAL CDE program. The CDE program will ultimately have implications for clinical, preclinical, and translational research, as well as clinical practice and public policy. The diversity of clinical pain data being collected by HEAL investigators will enable future investigators to conduct secondary data analyses that are biopsychosocial in nature and across a variety of pain conditions and management treatments. Using a comprehensive core outcome set within HEAL will lead to a more nuanced understanding of how pain affects different patients, and how different therapies affect the whole spectrum of pain-related effects. The core supplemental case report forms and common data element detail forms can be found on the NIH HEAL CDE box account. HEAL pain PIs have to use the variable names and the coding of the measures that the HEAL CDE team provides on the box account. If your team would like access to the HEAL CDE box account, please either email myself or my colleague Andrew Siddons. Our emails are listed on this slide. We have heard from PIs that the system can be challenging to navigate. So while there is a new system under development, this is meant to be easier, but in the meantime, we welcome suggestions for how we can improve the functioning of the box account. The HEAL CDE program has a website that you can look at. The NIH has also published a journal article summarizing the HEAL CDE program listed here on the slide. HEAL PIs have identified a few challenges within the HEAL CDE program. The first challenge is that the HEAL PIs have noted that it can take many months to receive copyrighted licenses from copyrighted license holders, particularly MAPI Trust. We recommend that PIs request their licenses during the beginning of their planning year and/or as soon as they are funded. We have also been working with MAPI Trust to try and improve their turnaround of licenses. So moving forward, HEAL PIs requesting licenses from MAPI Trust should mention that they are a HEAL PI in their license request form, which should reduce the amount of time it takes them to issue a license. Some HEAL PIs and programs, for various reasons, have also indicated that they're not going to code their datasets with the HEAL CDEs until after completion of their study. We expect that PIs and programs will have some questions about how to appropriately code their dataset with the HEAL CDEs at the end of their study, and this may result in delaying submitting data to the HEAL data ecosystem. Some HEAL PIs and programs are coding their datasets prior to starting their studies, and we strongly recommend that PIs and programs to code their datasets prior to the beginning of collecting data or whenever this is possible. We have been made aware of a few data issues as PIs are implementing their CDEs, and as we are made aware of these issues, the HEAL CDE program has been working to fix the issues. So for example, some of the HEAL CDE variables were more than 26 characters, which means that the variable names in REDCap became truncated. The CDE team has been counting the characters in the variables, but if we miss a variable and it is brought to our attention, we fix the variable names. We've also been told that some coders have found that some of the variable coding conventions were difficult to implement in REDCap, for example, the sleep duration variable. And when we were made aware of these issues, we have updated the CDE details and provide coding instructions in the CDE details. Some PIs have also identified that some of the variable naming conventions are not as user-friendly. For example, the race variable names in the core demographic CDEs. And we do want to note that the HEAL CDE program, as much as possible, has tried to follow CDE standards. Thus, some of the variable names and naming conventions are a little bit more complex than normal. We do apologize, but we do hope the PIs and programs understand that the naming conventions will make the data more findable in the future. We want to discuss some future directions that the HEAL CDE program is currently working on. First, NIH staff and the HEAL CDE contractors are preparing the HEAL CDEs to be included in a broader CDE repository managed by the National Library of Medicine. This should make the HEAL CDEs more findable. As HEAL is continuing to launch new programs, we want to make the HEAL CDE program more sustainable. Thus, we're in the process of developing a ticketing system to track all of the questionnaires the PI plans to use in his or her study, submit new supplemental questionnaires to the HEAL CDE program, request copyrighted core measures, and track PI's status of requesting copyrighted supplemental questionnaires from license holders. Also, the HEAL Cde program plans to share the core CDE REDCap data dictionaries within HEAL, so HEAL PIs who have not coded their data dictionaries or who have coded their data dictionaries can see some examples of gold standard data dictionaries as PIs prepare to send their data to the HEAL data ecosystem. And with that, I'll end my talk. We're happy to take questions at the end of the webinar, and we look forward to working with you in the HEAL CDE program.
All right, I'd like to thank Dr. Wadner for sending us this wonderful pre-recorded presentation. So now we will be transitioning over to my colleague, Gaurav Vaidya, who will take us through some more information about the HEAL CDEs. Gaurav?
Thanks so much, Kira. If you could go to the next slide. So far, Dr. Wadner has talked to us about common data elements and given us an overview of them. What are they? Why are they important? And what are they used for? For the second part of this webinar, I'm going to be talking about existing HEAL efforts around CDEs, which right now is divided into is targeting three main questions. How can we make HEAL CDEs more readable and reusable? How do we make CDEs easier to find? And how do we make data collected with CDEs easier to find and work with, easier to combine and work with? Next slide. So to answer these questions, and the goal here is that CDEs will make biomedical data easier to understand, share, and reuse. And to give a little more detail on how exactly they can do this, I'm going to walk you through an example of a HEAL CDE. This example is available in the HEAL CDE box directory that Dr. Wadner talked about earlier, which you can get in touch with her or Andrew to get access to. So this is within that box directory, you will find PDFs and Word documents that have printable forms of these HEAL CDEs, which have all of these questions for either patients or clinicians to answer. If you go to the next slide, these forms are sometimes called questionnaires or case report forms. They're made up of individual questions. The questions are themselves the CDEs, the common data elements. And each question within the form has a question text and a list of permissible values for questions that have a certain set of permissible values. Alongside these PDF and Word documents, there are also Excel files that describe, they give you more detailed information. Oh, could you go back to the previous slide? Sorry. They give you more detailed information on what each of these, on definitions of why this question is being collected, citations that tell you where this question comes from and who originated it, as well as some information about how its use has been validated. They also have standardized variable names. And this is really important because this means that if you open up a HEAL data set and you see a particular variable name coming from a particular CDE, that tells you exactly which question was used, the exact question text that was used to ask this question, and what the value in that field means. So in these examples, for instance, with the first question, are you able to do chores such as vacuuming or yard work? We know that if the person said without any difficulty, it would be notated as a 5, and with a little difficulty, it would be noted as a 4, and so on. Between these two pieces of information, the printed form and the Excel sheet, this is a really rich amount of information that the HEAL CDE team has assembled on each of the CDEs that are of interest to them. The Excel file is something that can be read programmatically, but in order to make the Excel file even more accessible to more people, Dr. Wadner mentioned that we're trying to publish these HEAL CDEs to the NIH CDE repository. Next slide. Once they've been uploaded into the repository, they'll look something like this. This is the exact same question that you saw earlier, but coming from a different project, from a different form, from a different project. But you can see that it has the same kind of information: the question text, optional information on the definition and other information about it, and the list of permissible values. There's even additional information in putting this information into the NIH CDE repository. We also get links to other resources such as UMLS and the NCI Thesaurus and LOINC, which further allows us to understand exactly what each of these different permissible values actually mean. So this is a quick overview of what a CDE actually looks like and what they look like within the box directory. So let's see how this can be used to answer these questions that we have. So how can we make HEAL CDEs more readable and reusable? To begin with, we have the format suited for reading and reuse. We have a variety of different formats that are suited for reading and reusing CDEs. We have the human readable formats, such as the Word and the PDF documents that are already in the box folder. We have machine readable formats like Excel, which is already in the drop folder, the box folder. Internally, we've been using JSON files we've been converting these Excel files into JSON files to make them more machine readable and to allow us to translate them into even more formats. For instance, if we were, for projects that are doing data collection and analytics, we would like to convert these CDE forms into REDCap forms, CEDAR forms, and Qualtrics forms, depending on which ones are most needed by the researcher community. These are all softwares that allow you to publish these forms for people to fill in, either within the REDCap software itself for REDCap, or at an online location where somebody can log in and provide the information that you need for your studies. And we also want to make these CDEs as shareable as possible through repositories like the NIH CDE repository. So the second question we're trying to tackle is, how do we make HEAL CDEs easier to find? And the reason that this is such an important question is because apart from those core CDEs, which are very well organized, there are over 500 CDEs that are part of, that are included as supplemental questionnaires. And on the one hand, this can be a challenge for researchers to figure out which forms are relevant to the questions that they want to ask. And of course, it's going to be a challenge down the road where somebody wants to see what data has already been collected by HEAL and figure out what data they want to look at, or what data they want to combine with data that they're generating elsewhere. Now, the HEAL team has already done a great job of organizing this into folders based on what each form is related to. But something that we're experimenting with right now is using named entity recognition software to actually look at the questions and descriptions within each form and use that to identify concepts that are related to each of these CDE forms. So for instance, on the next slide, if we have a set of CDEs, we'd like to connect these to concepts such as restlessness, sleep disorder, sleep disturbance, and just this huge list of conditions, anatomical locations, and all of this other concepts that we have that we think will be useful to find the CDEs that somebody is interested in. And as Dr. Wanda mentioned, we're also recording which studies use which CDEs. So the dream here is for somebody to be able to come into the HEAL CDE data ecosystem and to say, I'm interested in data relating to sleep disorders, to find the CDEs that are related to sleep disorders, and then to find the studies that have collected data using these CDEs. And that leads to the third point that I'm going to be talking about, which is how do we make it easier to combine data sets collected using HEAL CDEs? Now, this is going to be the big big dream of CDEs. This is why we do all of this work for CDEs. We envision a future where a study collects study-specific data, but then it also collects data from a number of CDEs. And if there's a second study which collects its own specific data, but also uses maybe a different set of CDEs, we would like to make it as easy as possible for data collected using the same CDEs to be combined together and analyzed in some way. In order to do this, we would need the data to be structured with the variable names that have been provided in the Excel files. We would need the values used to be the ones that are required by CDEs, whether that's a permissible value or if it's a particular data constraint, such as a field needs to be a number. And possibly we will need some sort of software in the future to validate that data has been correctly collected and correctly notated. So this is the big dream that we're working towards, and this is something the HEAL data stewards are discussing and planning right now. So next slide. So summary or takeaways from this webinar. CDEs are standardized, precisely defined questions paired with a set of allowable responses used systematically across different sites, studies, or clinical trials to ensure consistent data collection. Your HEAL team can access the HEAL CDEs by requesting access to the NIH HEAL CDE box account by emailing Dr. Laura Wandner or Andrew Siddons. You can get help with using the HEAL CDEs by getting in touch with Dr. Wandner's group or with the HEAL stewards. And doing this work now is going to allow many, many others to understand and build upon your work in the future, which is why CDEs are so important, which is why I'm so glad we're talking about them today. Next slide. All right, so I'm gonna give the mic back to Kira so she can introduce the panel for today's moderated discussion.
All right, I'd like to ask my fellow panelists, Gaurav, Kathy, Diane, Meredith, and Andrew to please turn on their cameras. I will stop screen sharing and we will now begin the moderated question portion of today's webinar. So the first question is, what are the benefits of using CDEs? And I'd like to start off with Andrew first.
Thank you, Kira. So from our perspective in HEAL, the benefits of using CDEs are that the program itself provides an unprecedented opportunity for data harmonization across a large number of high-profile studies, allowing for analysis across the studies. And the CDEs can help facilitate cross-study comparisons, allow for secondary data analysis. And for the pain research community specifically, they can access meaningful data across different pain conditions in diverse populations and through multiple interventions. And if others may want to weigh in on that as well.
Yeah, so as the PI of the Coordinating Center for Empower, we've had sort of a microcosm of these CDEs and studies, because what we're doing is we've combined chronic pain and opioid use disorder, and then we've got 10 different R1 level trials across all these different sites. So what we did to harmonize was based on CDEs. So it's been an adventure, but the point of that is that while we're not looking at different outcomes and different interventions, we are applying these standards across. And so hopefully we'll be able to actually take some sort of larger learnings and takeaways from these combined projects. And, you know, using standardized CDE, both within our network, but then linking out to the larger network allows us to sort of have a lot more power with what we do and impact.
Excellent. All right, I will now move on to the next question, which is, who should use CDEs? Let's start with Meredith.
Okay. So, I mean, everyone should obviously use CDEs. They're amazing. No, I think that there are, you know, you can take a broad interpretation of what CDEs are. There are ones that are in the box, and then the out of the box, not to get too punny, ones that we have brought in are things from a wide range of domains. And I think that's where what's been kind of cool about it is we've been able to use the standard ones, but then also the stuff that we are building and adapting and sort of expanding have been folded in as well. And then if somebody wants to do the same thing later, they can look at our playbook and either use that or then build off it, or say, this is terrible, we should do something completely different. And that's okay too, but it gives you a frame of reference, which I think is really important.
Anyone else? Andrew, do you care to comment on who should use CDEs?
Sure. So in addition to the broader research applications and utility of CDEs, for HEAL clinical pain research studies specifically, those researchers have to use the CDEs that we've designated for the 9 core pain domains. And then if they're using the supplemental CDEs, looking to see, or if they're using supplemental questionnaires outside of the core, looking to see which ones already have uniform CDEs from HEAL, or submitting them for so we can put them in the system and they can be used more broadly in the future.
One just follow-up comment on sort of the required CDEs. In some of them, we went a little bit off-label, if you will, in that in some of the demographics, we wanted a little bit more granularity, like in sexual identity. So there's the HEAL required ones, and then we expanded those. And then in other areas, we went a little bit deeper than the surveys that were required for sort of surface stuff. And so we were able to sort of work with the team and get credit for those. And we'll probably do stuff on the back end to fit the original CDEs, but there was some flexibility with that. So I think they were really willing to work with us, which was very helpful.
Excellent. All right. So how do we get access to the HEAL CDs? Hopefully folks were paying attention to the presentations, but if they have not, Andrew?
Yeah, it's pretty simple. You just have to reach out. I think our email addresses were put into the chat, and we've also our colleagues at the University of Utah, led by Diane, are also going to be taking more ownership of this process as well. So for now, the process just involves reaching out to one of us. At some point in the not too distant future, it may become a little more automated.
I was going to ask that follow-up question, but you anticipated me. All right. So are we required to use CDEs?
If you're part of the HEAL clinical pain programs, yes. And I think if you're on the call, you probably know if you are or not. But that'll also be required for upcoming programs that are launching later this year that include research related to health disparities and health equity. But we also, I've been contacted by those who are on the OUD side of the house, and those who aren't in the clinical pain program, who have expressed interest in using some of the pain questionnaires. And so we encourage any HEAL study to use questionnaires and CDEs from the core, or what we've put up there for supplementals, if it's appropriate for your study, even if it's not pain related. Or I should say, if it's not specifically pain related, because I think many of the OUD studies probably have a pain question of some sort.
So if I were a researcher wanting to use CDEs, but I realized that there weren't any that are currently available that match exactly what I'm looking for, when should I consider creating a new CDE? Let's hear from Andrew first, and then Meredith, I'd love your PI perspective.
So again, if your study is using questionnaires outside of the core, and that others haven't already submitted to our supplemental repository, you just have to contact us about usage of the questionnaire, and we will work to compile HEAL specific CDEs for it.
Yeah, so we actually had, I think, somewhere around 60 surveys when we got done with, and we're still sort of finalizing some aspects of it. So I'd say much of our work was something that the team had to make de novo for us and didn't have in there, and had to assign names, and they did that as quickly as they could for the volume that we had. Our perspective on this is we are building something that will be on the Gen 3 platform. And so we're going to have a data commons, and we're trying to build in a way that is, I'm not going to use the word lazy, I'm going to go with efficient, by sort of naming everything on the front end with all of the names that will line up with everybody else, we can hopefully then make it just so much easier on the back end. So we're not going back and doing data analyses that have to, really kind of shift what you do and rename things, and it gets complicated with all the different sites. This was not a simple thing, so I'm not being glib about it, because we had to coordinate pretty much everything before everyone could launch their studies. And with 10 different studies, it's a lot of moving parts. But we had agreed upon CDEs. And then we had things that were like health economics and stigma and perceptions by providers and a whole bunch of stuff that is hopefully going to be really cool when we collect it. But it was something that we wanted to get built in a way that, if we collect this and then other people see this and want to use the same things, they can kind of mix and match from the menu and build things that line up. So, as we mentioned earlier, if you're looking at larger studies and trying to combine things, we want to be set up to just move things forward and do these bigger sort of searches and analyses.
So out of curiosity, Meredith, have you ever, working with the other 10 studies, did you run into a scenario where there were existing CDEs that you wanted to use that weren't HEAL specific?
Yeah, a lot of it is that people had their preferences on surveys, and some of it would be like, we'd have the something on a specific drug or like a cannabis thing that we were adapting. And so we take some of the base things and then modify based on what the research sort of questions and what we needed answered. And I think that we really tried to, if at all possible, use something that's standardized, if not customized. But again, we're at that point where we're going to go back, and I sort of feel a little sad because Andrew and Kathy are going to have to go through all of this with me and just make sure that we catch all the changes that we made, because we had to, as you go through and program and do other stuff, there are shifts. But I think the intent is to allow the science to happen in a way that allows both your individual project and then the larger sort of portfolio and picture of the science to sort of move forward at the same time.
So Andrew, should the scenario arise that investigators want to use an additional set of core CDEs in addition to the HEAL CDEs, what's the process they should take to incorporate that?
Again, if they'll use the core, and then anything that they have outside of our defined core, they may have their own, what they define as a core. We would consider that supplemental. It would be the same process of working with us to standardize everything.
So this next question is my favorite question. If you have been following us on our Fresh Fair webinar series, you will know that I had recently as January, did a webinar on data management and sharing plans. So this question is, do I need to include the use of CDEs in my data management and sharing plans? Andrew, what say you?
So I'll keep this one short. The answer is yes. But then maybe some of the rest of you want to weigh in on what goes into the data as people who have either worked on them or advised on them. You might want to comment further.
Okay, I feel like I'm doing a lot of talking, but I would say one of the things that's important is to realize that this is going to be a moving target. Things are shifting constantly with what the requirements are, but also when you get in and you start developing your study, if you're in something like our sort of, jamboree of CDE, or if you're in something a little bit more, constrained, you may have to shift things as you go along. But I think just the general principles that you're going to be aligning your CDE with the required, and then you will, try and adopt things I think are sort of good practices, because ultimately, you want your science to be impactful. And if you can take what you did and then sort of expand it to a larger network, one, it's super cool. But two, it also, I think, helps the whole team, which is really, I think, sort of a nice thing about this.
All right, let's speak a little bit more about impact, Meredith. How did CDEs impact your research positively?
How they, well, I think some of it is that sometimes this feels rather thankless, like you're doing a lot of these sort of like data organization, and it's sort of like organizing your closet, and you're like, what's the point? I'm just going to take out all the shirts and it's be a mess again. And with this, I feel like we're building something that builds towards the future, in the sense of we are, aligning with studies that are already out there. And what we were very cognizant of, I'm talking with my hands with it already, I get excited. We're lining up with existing studies, and we really tried to make sure that we went with what people were already using when we could, so that we can build towards different things. And then I think we also were sort of letting it be something where, again, as people are looking into if they want to do something on stigma, or if they want to do something that is looking at some of these areas where we're looking at some of these other cognitive domains, it really brings forward some areas that have some meat so that people can have something concrete to latch onto. And I'm hoping, sort of as early adopters in the system, people are going to like what we did and start using it in their projects, which then helps, us then sort of build down the ladder.
So I will say, as someone who has heard about Marie Kondoing my closet, I have seriously considered doing that. So I wonder if CDEs is a version of that. But can you tell us a little bit more about some lessons learned while implementing CDEs?
Yeah, so I think one of the tricky things is that, there's sort of this like hand wave of like, and then we did the CDEs, and it is not that. You've got to really normalize the fact that it's going to be, and this is for all the program officers in the room, you've really got to allow for time for that to occur, because if it's something where there's a decision-making process like we had, it took us months and we were working hard. Thanks to Chile Sue for all of your hard work shepherding us through that process. And then once we did that, then because we had so many new things, we needed to work through the process of humans processing our information and turning it into stuff. The next step was we decided that we were going to use REDCap, not Qualtrics. And the reason really came down to the ability to do metadata with that, which sort of speaks to that larger use and building towards the future. Our group is really sort of interested in that, and looking at things like OMOP and other things that we're working towards with it as well. But it's really just letting it be something where it's going to be a process, it's going to be a thing. We wanted to REDCap again because even though REDCap is not flexible in some ways, it does allow for CDISC, which lets us do sort of concept mapping, hashtags, if you will. So I went through and mapped our entire 800 CDEs and to different concepts. So if it's a Narcan question, it has that. If it's buprenorphine, it has that. All the different pain diagnoses, the concepts are there. A lot of the promise measures have concepts that are mapped as well. And the point there is there may be a study that doesn't use my exact CDE, but if they're looking at stigma and they have the same thing, at some point, hopefully someone will have a framework where you can just search stigma and all of our CDE will come together. And I think that's where there's sort of that data magic, in the sense of we don't have to do that cognitive load if we build a framework for this data magic to happen.
Yeah, data magic and the dream that Gaurav was speaking towards in his presentation.
Exactly. We're building the dream. It's not a dream. It's like just a couple-year plan.
Okay, I like that. All right, so this will be the last question for our moderated panel conversation. We have live Q&A coming in fast and furious, but for our last moderated panel question, who do we talk to if we have technical questions about what's actually in the common data element spreadsheets?
So that would be, you could funnel your questions through Andrew or Diane. Diane has set up an email address. You can also ask the HEAL ecosystem stewards and they'll funnel them back. Ultimately, those questions will come to my team. Because we're so immersed in those Excel files and the details of those data elements, we can usually help you figure them out. But start with either Andrew or Diane. Do you want to mention your email you set up?
Yeah, I'm just going to drop it in the chat for the hosts and panel. The hosts can share. It's very simple: heal_cde@hsc.utah.edu. But I'll put it in the chat.
Beautiful. All right, so I am going to be funneling questions to the panelists. Gaurav will be asking questions on all of our behalves. So please keep your live Q&As coming, and we will try and get to all of them. Gaurav?
All right, so here's the first live question. Does the inclusion of a set of allowable responses in the definition of CDEs suggest that free-form responses would not be appropriate inclusions in a CDE questionnaire or set? Who wants to take a stab at this first? Kathy.
Yeah, I'll tackle that. We actually have a number of CDEs that are free text elements. They can specify something like a number, can specify a date, can be a set of coded options like we saw, or the data element might be most appropriately addressed through free text. And there are data elements that use all those formats.
Would anyone else like to add anything? One thing that I want to throw in is that even where a CDE has a free text box, it usually provides some guidance about what needs to go into the box. So it won't just say record the length of your arm or something. It'll say how it's being measured, what units to use. And that's something that's going to make the data easier to combine in the future. Question number 2. Sorry,
I was going to say, and also sometimes you have free text with things like other, you'll have a question and you have a list of things. And the most common thing that we have that's free text is other. And that's because it gives people a chance to answer, or patients or whoever's participating with what's really going on with their situation. And I think that's really normal. I think you were just showing one that had like the standard kind of like promise sort of answers, but a lot of them have a lot of flexibility.
Great point. Yeah. Does anybody else want to add anything? All right. Question number 2. Are there any CDEs for neonatal studies?
So most of that's sort of a it depends question. The CDEs in the child domain for the core should be applicable for neonatal. In terms of the supplemental instruments, it depends part is that these are being built based on what has been funded as a HEAL study. And so to the extent that neonates are part of existing studies, but I don't know of any that are like exclusively neonatal at this point, because I don't know of any studies that are exclusively neonates at this point.
Anybody want to add anything? I think that answers it. Question number 3. I really like this question. When your current 500 study-specific CDEs grows to become 50,000 study-specific CDEs, have you not lost the benefit or value of CDEs? Does HEAL have governance to say no to a proposed study-specific CDE to prevent this from happening?
So the 500 are questionnaires. There probably are close to 50,000 individual elements at this point already, but the majority of those supplemental items are still validated questionnaires. There are actually not a huge number that are purely study specific. Most of them are either other kinds of validated questionnaires that just weren't part of the core, or are modifications from validated questionnaires where they may have just tweaked, saying back pain instead of just pain generically or something like that. Does HEAL have the governance to say no? We tend to be a little more democratic than that. Laura will sometimes nudge a study team about, well, have you really considered, do you really need to use this, custom questionnaire, or it's so similar to this other validated instrument, would you want to consider it? We have had a few times where we put study teams in contact with each other and they sort of negotiate it out. And, Meredith, you mentioned about how you use the same instrument over a lot of studies, and sometimes what happens is the questionnaire will drift, and sometimes just helping people understand how they've drifted can bring them back to saying, maybe I don't need this custom version. Maybe I can go back to the validated version or an update of the validated version. So it tends to be more of a conversation than a hard no.
I think also with that is, as you said, some of them are adaptations. And for us, some of it was that things were covered in other areas. And so to avoid redundancy, we chop off some. But some things, like we came up with a COVID questionnaire, and we had a required COVID questionnaire and then a slightly more in-depth COVID questionnaire. And there was nothing on the map for that. And we needed to ask it about chronic pain, and we needed to ask about opioid use disorder. We're also finding things like we're doing provider-facing surveys, and we realize there are no provider-facing demographics, and there are no provider-facing things in some of these areas. So we're building because we're following the science. And I don't think that, you know, on these approved studies that HEAL is going to turn down the science. I think if there's an opportunity where you might not realize that something is available, I think that might be something where that nudge might be helpful. And like in ours, you know, it was hours and hours and hours of conversation.
Yeah.
And I think it was really important, and I think it's impactful. And someday we'll try and publish that.
And many of those new
yeah.
questionnaires are going to be useful to the next person that comes
Right.
down
Well,
and has that need. So
exactly. And what we're trying to do when we get to the end of all of this sort of refinement era is feed these REDCap sort of data sets back to HEAL, because that way people do not have to reinvent the wheel, and they have a base framework to work off of. Some of them are a little bit tricky. REDCap is kind of clunky. You can't do CAT in it, so you can't do a computer adaptive testing. A lot of the programming has to be, to make it a little bit more user-friendly, you've got to sort of build in things in a different way, which is okay. And we've done that because our design constraints were, one, the science, two, having it be sort of aligned with the HEAL data elements, which is actually not necessarily easy to do sometimes in REDCap. And then also having it be patient friendly as well to try and decrease the burden as much as we could. So I think we feel pretty good about it. We probably messed some things up, and as we go, we find more things that need to be refined, iterated. But I think that's the thing where Kathy and I are pen pals, because she is very patient with me, realizing that I do not have there's nothing for a GUID, which if you don't know what it is, you may soon know what it is. But there wasn't something where you could have that was a CDE to identify that. So some of this, the build comes and it evolves as you sort of get into the project.
Does anybody want to add anything to those two excellent answers? All right. Question number 4. Do you have a way for people creating their supplemental CDEs to quickly find and reuse questions that have been used in other studies, sort of like a library of questions?
that is part of what Diane's team is working on at the moment. Is we have multiple, sort of lists, and they are actively working on bringing out that level of detail to make it more searchable. So it's good to know that that work is going to be needed, right?
Yes, definitely.
Mm-hmm. And I just want to add the NIH CDE repository is, I think, sort of planning to become that repository of questions where you can go in and find a question that's important to you, look for forms that are related to that, and see if they've been validated, or you can hand that question over to the HEAL CDE team and see if they have.
Absolutely, they have a good search engine.
Exactly.
Well, and when you're getting started, if you're not 100%, but you want something that's in, again, I'm using the stigma domain, you can just search the stigma folder and sort of see what's there and see what people have used and see where people have tweaked things. And I think that potentially could be helpful there. And I think some of it, as this grows and has things, I think there's going to be sort of a wide variety of stuff. I mean, we have a Native American spirituality scale in our surveys as a supplemental, which is probably not going to have a ton of use across many studies, but there might be the time where you want something like that and you're like, what are people using? And you'll be able to see what we've got.
Sweet. And does anybody want to add anything else? All right. Next question. For those of us generating novel data collection instruments, are there guidelines for structuring them to help with future knowledge discovery in this ecosystem? So how do researchers make new CDEs is I guess the question.
Boy, part of that comes to just your basics of instrument development and psychometrics, right? And I think going back to those core principles, I think as the infrastructure that your group is developing, Gaurav, where they're building out some of this modeling of the domains and the concepts, that can help a little bit in terms of thinking about how conceptually things fit together. But a lot of this is just your basic instrument development and validation process, and then we can help get it formatted for the HEAL format.
Yeah, in terms of the HEAL format, I was going to say that as far as I know, there isn't really a standard universal format for carrying CDE data at the moment. But the spreadsheet format, the Excel sheets that HEAL provides, is probably a good place to start. And if you formatted, go on, Kathy.
A lot of the information Meredith provided us was from her REDCap data dictionaries, and that provides a lot of the similar format for what we need.
Right. If you already have it in a questionnaire in any software, that's already a huge step towards getting it in. All right. Anything else? Okay. Next question. As CDEs develop, so there's two parts to this question. As CDEs develop, what's the process of incorporating new CDEs to the old and current data? And two, is there a process of retiring and replacing certain CDEs as science evolves?
So at the moment, the data question, I'm going to turf to Meredith, but in terms of retiring and replacing, much of the efforts are really guided by what are the HEAL studies doing. So right now, our process tends to be driven by a study saying to us, you know what, this questionnaire that we submitted to you 2 years ago has been updated and we've decided to move to the newest version. We check to make sure whether anybody else is using that questionnaire. If this is the only study using it, we may replace the CDE. If there are, we've seen cases of this, Andrew, where one study is using version 1 and another study is using version 2, and we tag those, so we'll maintain both versions if they're both actively generating HEAL data. So I think the driving question is the extent to which it's been used to generate data within a study.
Makes sense.
Now, Meredith, if somebody was going to bring a new instrument in the middle of the process, you want to brainstorm
after I cried?
Yeah, after you cry, then what?
After I cry and just shake it off, right? So I think it just depends if you can map it, right? Like some things like demographics, super easy, right? But some things that are a standardized measure that's been validated may be a little bit more tricky, and you may be mapping them more on concepts and CDISC than you would be necessarily on the variable names, because the variable names are pretty specific to each individual question. What's sort of makes some of the logistics of REDCap a little bit difficult is when you're looking at a survey and a paper survey, when you're asking someone's demographic question, like their gender, they're checking boxes. But in HEAL, by assigning variable names to all those answers, which makes it searchable, which is great, you actually turn each one of those into a question. So it sort of shifts how the data is collected and does things in a way that can be a little bit burdensome if you don't program it in a way that's helpful for patients. And I think those could be mapped later, but it really depends on the survey and the questions being asked.
And that's the last question that we had time for. So I'm going to hand it back to Kira to wrap it up.
Thanks, Gaurav. I just want to say thank you all so much. We have many more questions that we were not able to get to. So we're going to see if we can get some of the panelists to put not pen to paper, fingers to typewriters, computers to type out an answers. We will try and send them out to the registrants of this webinar. So I want to thank everyone who participated in this webinar today. A special thank you to our presenters, Laura and Gaurav, and our panelists, Kathy, Diane, Meredith, and Andrew. We are very grateful for your insights into CDEs. For the audience, we hope that you're leaving with a better understanding of CDEs and their importance in sharing data on the HEAL platform. So in addition to a recording of this webinar, we will also email everyone who is registered for this event a list of resources that will assist you as you participate more deeply in the HEAL ecosystem. This slide deck will be shared, and a link to our Slack channel and Connect with Us forum will be located in the chat box momentarily. We hope that you will reach out to us, the HEAL stewards, or to your friendly HEAL CDE folks for questions or support as you embark on your FAIR journey to maximize the value of HEAL data. Finally, we look forward to seeing you all at our next webinar in September. So we get a summertime break in August, and we will see you guys again in September. And with that, have a wonderful afternoon, everyone.